Can we see my screen?
Yes.
Wonderful. Okay, so this is your history for today's case. She is a Gravida 6 para 2 previous terminations, a miscarriage, and 2 SVDs, one of which was in 2009 and one of which in 2016. Medical history of migraines and a previous tonsillectomy. Her BMI is 38, however, that was measured at 38 weeks, so probably slightly less than that, considering she had a 30-week baby when she was weighed. Late booker at 38 weeks, so no previous antenatal care. She had an ultrasound scan at 39 weeks, which showed normal fetal growth, fluid, and Dopplers, and an estimated fetal weight of 4,135 grams. This was, I think, on like the 80th centile, 87th centile. She was an induction of labour for post dates at 41 plus 2. And on the 20th of the month at 16:35, she had a propus inserted. Her cervix was 1 centimetre dilated. Presenting part was -3. There was no CTG printed for this specific one, so prior to and just following her start of induction, but the baseline rate was 135 as recorded on Cerner. Just please be aware, I do have a few missing CTGs from time to time. It's really important to try and make sure that they're all documented and within the notes and whatnot, but hopefully that problem will be resolved when we get Fetal Link, which will be due in February next year. Okay, so this is the 21st of the month. She is on our antenatal ward at this point. So propus was put in, sorry, at 16:35. This was the CTG following that. So previous baseline 135. Note that she's contracting quite a lot on our antenatal ward at this point. So we're at about 4 to 5 in 10. Baseline rate has gone up from what it was in comparison to the previous CTG at around 145. This CTG continues further. And at 01:52, the midwife on our antenatal ward escalated this to the obstetric registrar, who made a plan to continue the CTG and to review the CTG in an hour's time. Anybody like to comment? This was the end of the CTG as well. So those 3 last segments were all on our antenatal ward.
The variability is very minimal.
Yeah, so even throughout the entire CTG, considering she had a propus put in sort of, you know, about 5 hours, 6 hours prior to this, the contractions have seriously picked up. So the propus is definitely put in the right place, and her induction process is, you know, it's working well. But yeah, and also we would hope to see some form of cycling within this period of like an hour and 20 minutes here. But we do have slightly reduced variability throughout pretty much the entire segment of trace. And although they're somewhat discrete, you know, we can also see some decelerations here as well. There is some loss of contact as well. But yeah.
2 questions, please, Cara.
Of course.
One is, when was her previous delivery? This is one. And what was the size of her previous babies? And the second question is, when registrar says I will continue for an hour, I wish we just emphasized on one thing. Whenever we say I'm coming back in half an hour, in 1 hour, or whatever, to put a reason behind what we are doing. Like, I'm coming in an hour because I don't feel that CTG is enough to be so and so, or I am not concerned. But like, I want some thought process to be materialized in the notes, more or less. I want always to understand whoever is coming in half an hour or coming in an hour, coming to do what, and leaving to do what. So these are the 2 points that I want to know.
So her previous baby was born in 2019, and as far as I'm aware, this baby was on a very normal centile, under 4 kilos, and was around the 70th, 80th centile for the previous baby. So according to her growth scan at 39 weeks, which we all know has a massive sort of margin of error, if you like, you know, 70 to 80th centile for this baby is the same as the previous. So by assumption, obviously this was kind of normal for her. The second point, Mr. Naguib, unfortunately, the obstetric registrar didn't document anything about this CTG whilst following review. So came to antenatal ward to review the case and review the CTG, but unfortunately didn't document any reason as to why we were waiting an hour, or document anything around what the CTG entailed at the time. I'd also just like to point out to all of our midwives and whatnot, whenever we are experiencing something like this where we believe a CTG to be abnormal, as much as we do need an obstetric review in order to sort of carry on our care and whatnot, we also need to let the midwife in charge know, because it's great that we've escalated this higher, but actually the midwife in charge needs to be made aware of any abnormalities happening on the other units as well, because they're going to be the ones that allocate the midwife and decide which room they go to and whatnot. So it's really important that we're escalating better, and we're definitely getting better at it, but we're escalating to the correct people as well, and the midwife in charge is one of those people that needs to be informed. So looking at
Just
this
to
from
clarify,
sorry, Mr. Nick, no, go ahead.
sorry, Cara. Yeah, just to clarify to the midwives, I don't know whether this is clear for everybody or not, that the midwife in charge in the labor ward is the highest in the hierarchy of the midwives who are on the shift. Just in case, because maybe people think escalate to the midwife in charge in antenatal, or no, as you said, the midwife in charge in labor ward.
Yeah, absolutely. Absolutely. And from an antenatal perspective as well, I mean, she's had a pregnancy in for sort of 6 or 7 hours at this point. She, as far as sort of your classification goes, this CTG is still abnormal. She's not been re-examined within this time frame, so we don't know at what stage she is in her labour. But also, I would encourage the midwives that are picking up these antenatal CTGs that are abnormal to do things such as, I don't know, remove the PROPES. We don't necessarily need to have an obstetric review before we perform any actions ourselves. As much as we want the sort of clarification, and we should be informing the MDT, if we're in a situation whereby we can clearly see something's abnormal, we need to know what we can do about it. If we're waiting for a time, we all know what labour ward can be like. We know what our antenatal ward can be like. But if you're picking up on something that you believe is abnormal, we really need to try and do something about it ourselves before we wait for others. And I think in this case, if we're picking up reduced variability for an hour and 20 minutes, and she's very almost tachysystole as well, we need to be able to try and remove any of those triggers that could be stressing this fetus even further. Okay.
Was there a suggestion to remove the PROPES while we are waiting the hour?
Unfortunately, Mr. Naguib, nothing's documented. So when the obstetrician came to do a review, there was no plan put in place on Cerner.
Neither by the midwife?
No.
Okay. Yeah, thank you.
Oh. Okay. So at 03:05, the CTG was put back on. I think there's some loss of contact, or the timing's just slightly off. Maternal pulse was 89 at this point. the difference in these CTGs is about half an hour, 20 minutes essentially. But then obviously we can see here that this baby's under somewhat of hypoxic stress. So meconium was also noted at 0305. She was put back on the CTG, and then shortly afterwards she was transferred to labour ward. Looking back,
sorry, Cora, was
yeah,
the CTG review by a reg?
yeah.
So there's a second review.
No, so this is the initial CTG, Indra. Here, the registrar reviewed at around 2 o'clock. And then said to keep it on for an hour. So that's pretty much what the midwife did. And then it was taken off.
So we took it off while it was still abnormal.
Yeah. So we took it off while it was still abnormal, and then when MEC was noted, the CTG was put back on, and this is what we had.
There.
Dagmar put in the chat. I don't know what. Maybe she can't comment on the mic. So she said, thoughts one, I'm booked until 38 weeks. Dating is ±4 weeks off. Hence, induction of labor at 41 + 2 is potentially very much off. Two, baby was 4.1 kilo at 38. Growth is 280 grams per 14 days, meaning 41 + 2, we are dealing with the baby potentially up to 4.5 kilo.
Yeah.
Point 3, 4.1 kilo at 38 weeks appears rather large, evidently at this stage in pregnancy, no OGTT, but potentially she had glucose monitoring, possible, we don't know. 4, what was this baby previous baseline rate? It is now 140, which is in range, but the important part is what is normal for this baby. Variability is less than 5 with tachysystole. With this contractions, one cannot remove CTG, but remove the propes, which exactly. Yeah, I agree completely. All the points are valid, and
Me too. Yeah, absolutely. I think, when it comes, this lady's a para 3. As far as I'm aware, there was no serious complications or anything major that had happened in her previous pregnancies. I think they obviously had been quite straightforward. When it comes to our induction process, I think, our late booker sort of around 18 weeks and whatnot isn't necessarily a reason to induce at an earlier gestation. But I think, 38 weeks, 4.1 kilograms. Like you said, obviously an additional sort of 250 grams every 14 days. That's quite a significant amount of growth, specifically to wait another 3 weeks following that scan. 2 weeks following that scan.
And plus that that BMI is completely wrong as well.
Yeah.
So this baby could be on the 100th centile for all we know, 38 weeks.
Yeah, absolutely. There's a lot of grey area here, but I think, absolutely this should have been reviewed a lot earlier on. GTT she didn't have, I don't because she didn't have any care. And she didn't have any BM monitoring either, because we do our BM monitoring based off of sort of centile. And also she didn't have any polyhydramnios noted on that scan. I don't know whether they did a random blood sugar or not, just purely based off of the sort of size of the baby, but I don't believe they did. So yeah, we've got a lot of risk factors here, haven't we? Meconium being noted, we would almost somewhat expect that at this sort of gestation. But at the same time, knowing all of our risk factors, she's had no antenatal care. We don't know whether she's diabetic or not. This baby's going to be large regardless. BMI is completely off. There's an awful lot of things here that contribute to a very high risk woman. And I think maybe somewhat of an induction process on maybe labour ward or a quicker review would have been quite beneficial, specifically when we picked up an abnormal antenatal CTG here. But
I wouldn't particularly induce her in labor ward, but definitely once the CTG was abnormal,
yeah,
propus should be removed, and if it doesn't settle down, for terbutaline.
yeah,
Next is as we always ask, is this baby fit for labor?
yeah,
No, it's not. Terbutaline is fine. Then theater. It's
yeah.
not that we give terbutaline and sit, or at the same time see the CTG and leave the propus in. So yeah.
Yeah, absolutely.
Pam,
Okay.
was the propest removed before she got moved to labour ward?
I don't think, no. As far as the documentation goes, Beth, no.
I think the propers came out when she shrunk.
Oh, okay. Perfect. Thank you. So yeah, would have come out around at the time of this CTG. But even still, like I was just sort of saying, you know, we've got an abnormal antenatal CTG, and she's tachysystole, and she's quite a high risk woman as well. The propest should have been removed. I would say about 30-40 minutes into this, when we noted that this baby wasn't cycling, this was actually reduced variability.
Also, if I understand, or I don't understand the rationale of waiting an hour, but it's fine. What was the rationale to remove the CTG or stop it?
That's a very good question, Mr. Naguib, and unfortunately, again, this isn't documented anywhere. The plan was because I think the plan was to remove the propest after an hour. Because of that, because the plan was to continue the CTG for an hour. I'm yet to have my sort of rounds of my one-to-ones, but I believe the rationale was, okay, well, the obstetrician said, if I'm thinking in terms of my like midwife hats on, the obstetricians asked me to do an hour-long CTG. Certain members of staff may think, okay, so after an hour, then we'll just remove it, without actually looking at the overall clinical picture here. And I think that's what's been missed. Taking human factors into account as well. This is obviously at 3 o'clock in the morning, you know, on a night shift. So there's an element of that we do have to consider as well. But the moral of the story here is that actually we needed to do something about this quite a significant amount of time earlier. So
Brilliant. Yeah.
she's brought to labour ward now. This is her CTG. Sorry, I forgot to answer Dagmar's question. The initial baseline when she came in for her induction was that 135. That's what's recorded, but again, unfortunately, we didn't have the initial CTG. It wasn't printed, or it wasn't filed in her notes, so it's likely to have been lost. So I'm just going based off of what was documented on our Cerner. At 03:40, the doctors come in and do a quick ward round. The plan is to examine her in 4 hours, gain IV access, and the conversation was had with this woman, re the risk factors of big baby, and this woman was given the option of having a cesarean section at this point in time, or continuing on and trying to attempt for a vaginal delivery, because of the fact she's had 2 previous normal spontaneous vaginal deliveries.
Again, I slightly object to the word options here. If I give the option for somebody, and I'd say the option is, as a clinician, one is to start Cento, for example. I can't give an option that I cannot do. I don't know, or more or less, it's not an option. It is,
Yeah.
I don't know. It is slightly weird to give an option that you cannot give.
Yeah. Absolutely. Note here as well that our baseline is now sat at 150. whereas our original baseline was 135. So we have got an increase in baseline now. We still do have reduced variability, and we do have deceleration still present.
Clara, was she a late booker because of like asylum seeker coming to the country late? And if so, did she speak English and was language line used? Did she fully understand the upfront?
Yeah, I believe so. I don't know the reason why she didn't have any access to antenatal care, but she spoke English, that's for sure.
And at this point of time, Cara, you said there is meconium?
Yeah.
So meconium plus the trace in front of us now.
Yeah.
And the decision is made for another 4 hours.
Yes.
Okay, thank you.
So doing our sort of Dr. C bravado here, our risk factors are, MEC, big baby, late booker, no antenatal care, likely to have a scan that has quite a significant margin of error when it comes to size. We're not 100% certain with the gestation of this baby either, but we're currently going with she's currently 41 plus 3 because it's past midnight now. And we've got an abnormal antenatal CTG.
In early labor.
Can I just add, Cara, how many centimeters was she at this stage, please?
She was 2.
Thank you.
Okay, so we continue. So cannula's put in. She's going through periods of having quite a long break with contractions, and then they are sort of picking up very, very frequently. We've still got decelerations with the majority of our contractions. There's some loss of contact noted here. I think they put an FSC on. Yeah, they put an FSC on when she came to labour ward. Sorry, I forgot to mention that. That's when they discovered she was 2 centimetres, hence why the CTG is blue. So yeah, even with the loss of contact, this is an FSC that's put on. This continues. She's still having decelerations. Her variability is still very much reduced. We've still got meconium lichor that's draining. Anybody want to sort of suggest what our plan might be for this lady, or what we maybe could have done?
I don't really see what waiting is going to do. She's 2 centimeters. She's not in labor. The trace doesn't look great. I don't understand what waiting is going to do. So I feel like she's delivered. I know she's a para 2 and she's had 2 S3Ds, and should we wait and see if she, progresses to fully and delivers? But I mean, her trace was already horrible from the antenatal ward however many hours ago.
Yeah.
We've waited long enough, so I don't really understand what we're waiting for, really.
Nor do I. I think the opinion was very much, well, she's a multip, so she'll continue to deliver. That's the kind of impression that I get from our colleagues that were involved in the care. And there was also quite a significant difference in opinion here between the midwife in charge and the registrar. Just to sort of add that in, there was that discussion that had been had, but I think the overall end plan was, okay, we need to just sit and wait approach kind of thing for this lady. But yeah.
I think, irrespective of this case, it is the fruit and the result of many years of culture in at least when I came to the UK about 20 years ago, which is a drive and a strong drive for a vaginal delivery, and a shame that is hanging upon any midwife or obstetrician to section any multiple. And this culture continues to be in all, I cannot even say one with a dozen. In all clinical governance, when we present the dashboard and suddenly the section rate comes up as whatever, and the eyebrows go up, and how come the cesarean section rate is so and so and so, and how come, and as if it is a criminal offense to section. So I'm not saying what is happening at the moment at the CTG is right, but I'm saying that it has a big background as well of years of a unnecessary and unjustified drive to leave people to have a vaginal delivery at all costs.
Yeah, we definitely see that a lot, and even more so with multips. It's, you know, we have to take this very much looking at the overall clinical picture here. We've discussed all of the risk factors associated with this woman, and I think, you know, we are very much all in agreement. But when you do have that background of, okay, well, she's had 2 previous vaginal deliveries, it almost makes people want to push it even further. And yeah, like you said, Mr. Nagib, the culture needs to be rewritten a little bit, I think.
Kara,
Yeah.
you said that the dilatation is 2 centimeters.
Yeah.
Yes. Even if she's had a previous birth, she's still literally not in labor. Yeah, so I don't see why we are considering or taking this fact that she's para 2. She is actually in latent phase, and this latent phase, we know even para 3s or 4s, they can stay in that 2 centimeters for a day or 2. So I don't see what we are saying here about the parity.
Yeah, absolutely, Beatrice. It's again, it's changing the culture. You're absolutely right. Obviously, she is in the latent phase of labour, but as we were just saying, the culture is that, you know, our multips are going to deliver vaginally. It's almost like it's not okay to deliver them via cesarean section. But yeah, we need to work on a case by case basis. Okay. So the CTG is classified as pathological as per FIGO by the case midwife. The midwife in charge is present at 0440. Plan is to change position and give terbutaline, and terbutaline is given at 0446. So around the 3rd blue bar that you can see here, that's when terbutaline was given. We know we've already got a raised baseline, and we know that terbutaline can cause sort of maternal and somewhat fetal tachycardia, so we're expecting that to go up. But we're hoping that maybe if we've given the terbutaline and relaxed the uterus, we can rule out the idea of possible uterine activity that's making the hypoxia even more hypoxic.
Yeah, again, we need to think of the consequences of the events. Like, I'm not against, again, here giving terbutaline, absolutely right, but terbutaline and go to theater. Terbutaline, resuscitate the baby, allow time, go to theater, fine. But terbutaline at 2 centimeter, and then what? You know, like, and meconium, and then what? It is like again, not committing. It is neither here nor there.
Yeah, absolutely. We continue further. So this is the 30 minutes post terbutaline. Maternal blood pressure is 135/74, pulse of 104, and a temperature of 36.1. She's given IV paracetamol. I believe this was for pain relief as opposed to sort of anything else. And the registrar does an examination at 05:37. She remains 2 centimetres, so the decision is made for a caesarean section. And pre-meds are given at 05:50.
There is some comments from Dagmar.
Yeah.
It says, what are the thoughts of the team regarding causes for high baseline rate and variability? High baseline rates, comma, variability, not high variability, no. And there is also lowering of baseline rate after terbutaline. Something to note in this case, which, yeah, it hasn't gone up in the as we expect, but like again, she wants us to, brainstorm and see why this is happening.
That's a good question, and it's actually one that I was going to ask, because I've never seen it before where terbutaline actually makes the baseline go back down to almost where it was before normally. We know that obviously babies don't sleep tachycardic. We know that terbutaline does increase our baseline heart rates majority of the time because it does cause sort of tachycardia and whatnot. But what would be the reason for it reducing and actually returning back to normal? Because the only reasons I can think of whereby the baseline reduces is if we have sort of somewhat treated maternal tachycardia as a cause of sort of dehydration, or we've treated we've got a baby that's cycling and is sort of reduced baseline just due to the fact that babies don't sleep tachycardic, or in other cases when the baseline reduces, it can be a sign of terminal heart failure. So if anyone has any ideas that they'd like to brainstorm, then please tell me what you think.
I think personally 2 reasons in this case, or I suspect are the reasons. I don't know whether it is true or not. Reason number 1, that while they are resuscitating the baby and whatever they are giving terbutaline, somebody is pumping IV fluid on the background. So this is something that we might not be seeing. Number 2 theory in my head is that terbutaline will increase the baseline rate, but at the same time, when you relax the uterus, the effect of contractions on the hypoxia that increases the adrenaline in the body of the baby to increase the heart rate and to cause, this progressive, as we call it, hypoxia is less. So the adrenaline release is less. So the baseline has come down. So more or less you relaxed the baby in a way with the contractions. So baby is more relaxed in a way, which is counteracting the tachycardia of the beta agonist of the terbutaline. I don't know. Possibly, I don't know.
Quick question, Ms. Nagib and Kara. Now that the baseline has settled to what it was before and the CTG looks somewhat, I would argue, normal, a discussion was had to continue. Would you have continued with labor at this point?
No.
No, myself, no, as well, Petro, for one reason. As Kara said in the beginning, there is, again, this CTG meeting is not a CTG management. It is a patient and baby management. CTG is just 1/10, 1/100, 1/1,000,000 of the whole scenario. You are 2 centimeters. You are meconium. You are a big baby. You are no antenatal care. You just landed in the country. You are -2, -3. You give terbutaline to relax. Okay, so where are we going? And are we going with no contraction to achieve? Like if we were 9 centimeter, I might have thought about it in a para 2. 9 centimeter plus one head, with urges to push. She started to open the bowels. I am emptying urine. I'm preparing. It is a different scenario. But 2 centimeter, we have quite a while to go. And with meconium, and you already calmed down the contraction with terbutaline. I wouldn't know. I wouldn't be fooled by a little bit of improving, especially that the chemoreceptor deceleration are continuing. I am seeing them in the second half of this slide. They continue to tell me, yes, you calmed me down slightly, but I am still chemo. I'm still not happy to be completely in utero.
Thank you. It begs then the question, what is labor? Because obviously discussions were had about this woman being in labor, and we're talking about regular contractions with the effacement of the cervix, but that was not the case in this woman. So the discussion was had where not a part of the CTG where the baseline dropped. Oh, it's normal now. Let's continue labor. Even offer augmentation of labor. Put Sinto up.
I think the fact that we've given terbutaline, the CTG, yeah, okay, the variability has improved, but if you think about it, where is it? We gave terbutaline at 0446. This is now pretty much an hour later. Yes, it has somewhat, the variability is improved and our baseline has sort of come back to a stable point, but we're still having chemoreceptor decelerations and they picked up again. So the likelihood is that we're going to continue even further. Yes, you could probably give another terbutaline to try and stop, the chemoreceptor decelerations occurring and to keep the uterine activity at bay. But you're not going to be able to get to a point where the uterus settles enough or the uterus only has a few contractions that you can then control it with oxytocin.
And again, what makes us think that oxytocin will have a different effect than her contractions? If her own contraction made it so bad, oxytocin will make it also so bad. So I'm not sure why are we like returning back to on ourselves.
Yeah. Perfect. Does anybody have any other questions? I think this is our theatre CTG here. I think the first sort of 7-8 minutes is likely to be maternal pulse. But our baseline goes sort of back up to sort of 130, and we still are having decelerations in the operating theatre as well. But does anybody have any further questions on this one at all?
It's a comment, really. I want to say that when you argue with the opposite side of the story and people tell you, oh, but it normalized, oh, or this, and you try to tell them, okay, so what do you think is hypoxic? They will say, no, it's not very hypoxic. And I agree, we are not at the end stage of hypoxia. But what we are talking about here is the usual chess game that we play with the babies. We are playing with this baby a chess game that we know that your next move is checkmate. I know that you are not going to do it for me now because I'm doing terbutaline and so on. But because I know that I have 8 hours to go, for example, or 6 hours, and you will do checkmate in this 6 hours, I'm going to section you early. So yes, it's not hypoxia to the point of, like, if you ask me what is this gases, before the terbutaline, maybe it was 7.2, and then after terbutaline, maybe 7.24, whatever. But during the deceleration, you are having meconium aspiration. You can argue meconium aspiration is unpreventable, except if you section every baby. And also, when you section every baby, you might still have meconium aspiration. So the argument is of why are we sectioning? It is not hypoxic yet, or it is hypoxic but not enough to section. The counter argument is we are still 2 centimeter, guys. So we don't have the luxury of waiting all this time till we reach 10 centimeter with a big baby that might not even descend in the pelvis. So this is how we need to be thinking in a, like, really mind game with the baby rather than just reading and reacting. So we need to be proactive.
Yeah, absolutely. And if you think about it in terms of a marathon, this baby's not going to be able to sustain this for a prolonged period of time.
Hello, Mr. Najib. Hello.
Hello, Emmanuel. Yeah,
Hi,
hi, boss.
Sorry, yes. For some reasons, I've been waiting in the lobby. I was just been able to be allowed in not long ago.
Okay.
Yeah, so I joined very late. Yeah, so yeah, I came in just about when you were talking about the state of the CTG, about whether it is hypoxic or not, because that is the argument. You have a lady who is para 2. Para 2, yes, she might be having a big baby, even though, of course, we know sometimes the ultrasound, I mean, there are error margins even with the ultrasound finding, especially in our hospital. So if we're already committed to having a vaginal delivery, we don't, in this case, we have already committed to vaginal delivery anyway. We are not going for cesarean section. So if we're already going for that, we have a CTG that we are trying to manage. And we've had one vaginal examination that has shown that this lady is 2 centimeters and the baby is not hypoxic yet. If you are waiting, if of course you are looking at the CTG, you know that this lady may not, but she might, because a para 2, you can never tell. If you are waiting for the next CTG and say, let's wait for the next vaginal examination, let's see. Of course, if the CTG becomes abnormal before the next if it worsens before the next vaginal examination, or then of course you make a decision. But if it doesn't worsen, a para 2, there is a chance that the next time you're examining her, she may be fully. And if you're waiting for that, in this case, yes, that is the other side of the argument that I want you to comment on as well.
Absolutely. So that's what I was saying here, Emmanuel. But we need to be sure here what we are dealing with. So if I am looking at a CTG and I am seeing chemoreceptor, which are those shallows and with decreased variability, and this is telling me, oh, this is completely, and in an earlier 2 hours ago, when we go back in the CTG to a point of being abnormal, and abnormal to the point of rising baseline, decreased variability, and chemoreceptor deceleration. Even if some people now don't like to say chemoreceptor, like Mr. Ogumado was telling me, whatever. Late deceleration, whatever. We are seeing signs that this baby is not tolerating. Plus 2 centimeter plus. See, a scan is telling me big baby that is considerably higher than a previous baby. Plus a baby that was born a few years ago, and if I know well, this baby was born in 2015, so at least 8 years earlier.
2019, Mr. Naguib.
Okay, 2019. So yeah, number 5, we had to, us, not anybody else, us as the clinician, think I'm going to give terbutaline to calm down the contraction in order for me to resuscitate the baby in utero. So me as an obstetrician acknowledging that the contraction is causing progressive hypoxia in the presence of meconium. So all of this, not only the CTG, is telling me, am I going in the right direction? Is the train going to the destination, or the train is going somewhere else and I'm just slowing down with the brakes? So I slow down the whole situation till I see what happens. So I react. So my way of thinking, and I think, maybe I like to take this analogy from the programming I studied some times ago. I'm not going to wait for the computer to crash on me. I'm doing a flow chart and I'm going one step and then the next, then the next, then the next. And I am playing with the software. I'm playing with this baby a chess game. This baby is telling me things and I need to understand. And unless I understand what the baby is telling me, I will have my theories. Okay, 2 centimeter, yeah, now terbutaline, it is getting better. Okay, but getting better at the expense of what? At the expense of your contractions. And if you slow down the contraction, how come you are expected to reach from 2 to 10? So as if you are slowing down the contraction, Emmanuel, without a final destination in your head. You are just reacting to a situation. I'm slowing down the contraction. She's 2 centimeter. Let me CTG is better. Let me examine again in 2 hours. But what will happen in the 2 hours? You have slowed down the contraction. You are 2 centimeter. You are a big baby. So you are not going to achieve anything. You are just slowing it down. Like I got the handover in the morning today. And again, I'm not critical of any management. I can try to understand whoever is doing something. A lady who is VBAC, and somebody in the night decided that CTG is not good on Cento. So they stopped the Cento, and I would have thought you stop the Cento and section. Fantastic. No, stop the Cento and said section in the morning. By the morning, you see the CTG, it is textbook. Then the team comes in the morning and say, oh, why have you stopped Cento? Oh, because the CTG was abnormal. So why you didn't section her? Because it was in the night. So what is the problem in the night? Oh, but I don't want to section a VBAC in the night. But what was the aim? Okay. And then the team started Cento in the morning because the lady wanted a VBAC. I am not here again arguing the VBAC or not. I am saying that us as obstetrician, as midwives, we want to finish the night. We want to get over it. So our aim is sometimes give fluid, terbutaline, and wait. Wait for what? We don't have an aim. It is wait. And maybe we wait. And have I done this? Possibly I have done it at 7 o'clock in the morning. Terbutaline, fluids, and let's see in half an hour. What is the half an hour? Is the handover time. I am not excluding myself from the wickedness. Yes, all of us at some point of the night feel, I don't want to do a section. I don't want to do an instrumental. I don't want to have complication. I am tired enough. I just finished the ectopic. But if we exclude all these factors and think about this case without any other cases in our board, you will think in one way. Chemoreceptor, 2 centimeter, meconium. I have given terbutaline to slow it down. Thank you very much. I am thinking that her contraction is lethal to the baby, to the point that I am saying stop contracting by the terbutaline. So thank you very much. Let's end the game. Checkmate. Finished.
Sorry, Mr. Nagib. Sorry for taking us back because I didn't see most of this. Well, I'm sorry if I'm taking us back, but the chemoreceptors, was it before we did the ARM for how or after?
Kara can give you the initial one even in Hope Ward.
Yeah, before the ARM.
This was Hope Ward, Emmanuel.
Hope Ward, okay.
So this is Hope Ward.
Yeah, you can see here, Emmanuel, baseline. Yeah, okay. But look, variability is rubbish. Chemoreceptor shallows. And she is
at this point, has she had the ARM yet?
No,
she
ARM,
didn't
no
ARM.
ARM.
Okay. So, Mr. Nagib, my question here.
She's strong with meconium.
She's strong with meconium. Not ARM, isn't it? She's strong.
Yeah, and look at this, Emmanuel, here.
Yeah.
This CTG on its own is telling me. Yeah.
So, Mr. Nagib, my question really is this. Yeah. So my question really is this. I think it was Strom, not ARM. So what we are saying is that in this kind of scenario, probably what we should do, not to put her back on CTG from here, we'll take her straight for cesarean section. Am I right?
If you want me to be honest,
yes.
Yes. If I see this CTG, I give terbutaline and move her to theater. Yes.
Right from here, without even putting CTG, let you check labor ward.
No. Okay. In my opinion, yes. This CTG,
because this
2 centimeter.
Mr. Nagib, because this is the point. When this lady had that CTG, and then we say bring her to labor ward, what we are hoping is that let's put the CTG, because we do that all the time. We do that a lot. We don't take, a lot of times we don't take patients straight from Hope Ward straight to theater. We want to see how the CTG again will be when we bring her to labor ward. Should we put the CTG back? Yeah. Should we put the CTG back and it becomes normal on labor ward?
I don't mind. Yeah, I don't mind.
Of course, we can continue.
I don't mind you doing this in one condition. You put her back on the CTG in labor ward, you are like a lion, you are like a hawk, watching what is going to happen after your terbutaline. I don't mind you putting her in a room.
That's exactly what we're doing. Yeah, that's exactly what we're doing.
Look at the CTG. Look at the CTG here. We haven't done this because this is how many? This is 30 minutes. Then we have another 30 minutes. Then we have another 30 minutes. We have, so I don't know. This is what time? This is, help me, Kara. What time are we?
So this is labor ward starting now, isn't it?
So this is at 3:30 in the morning, Mr. Nagib.
Yeah, so this is the beginning of labor ward, yes?
Yeah.
Yep.
And tell me how we observed. Look, continue, Kara. Look at this, Emmanuel. How are we observing this and waiting? We cannot observe. You give terbutaline or what, or you don't give terbutaline.
No,
you
so
observe.
When she came to labor ward.
You observed in labor ward, and this is your CTG. How am I saying
Sorry,
to
Kara,
myself?
can you go back a little to the starting on labor ward? Yeah, starting on labor ward. This is the beginning on labor ward, isn't it?
Yes.
Yeah.
Yes. So starting on labor ward, this was the point. This was the decel that made us give the terbutaline. Am I right? This one, because when we started on labor ward and we kept our eyes on it from here, we felt it was slightly better. Sorry, go back to the same beginning. We felt at the beginning here that it was slightly better than how it looked on before she came to labor ward. But when she had this decel here, I think that's the point where we now decided to do examination and then we gave terbutaline.
So our point here, Emmanuel, is not a criticism. We are all
learning. No, it's a learning. Exactly, it's a learning experience.
It is a learning exercise. But if I am giving terbutaline on this trace, Emmanuel, we need to think one thing. The CTG in Hope Ward was not good. Let's say not good, and let's not do the classification so we don't go into criticism. Was not good. And then she contracted and shromed with nearly like subacute hypoxia that you saw in this 5 minutes. and then
Mr.
you get
Nagib,
her to
actually,
labor.
Mr. Nagib, actually, we can categorize it. We can. Baseline here
Fine.
is 150. Baseline
Yeah.
is 150. Variability probably be less than 5 or between 2 to 5.
Exactly. Thank
And
you.
then we have some, the D cell we are having here now.
Are chemoreceptors.
Yeah.
Good.
So,
And if you add this to the CTG in HOPE, which has been going for 2 hours, and you add it to meconium, that's why I'm saying to you, I don't disagree completely to you getting her to labor ward, but you get her to labor ward and you add 1 + 1 + 1 + 1, and it makes 4. You don't add 1 + 1 and then say to yourself, oh, maybe I will try terbutaline and make 1 + 1 + 1 and go back to one less because I calmed down the contraction, so we are 2 again. No, because I am 2 centimeter. What am I gaining? If
Mr.
you
Nagib,
ask yourself, yeah,
can I just add something, Mr. Nagib, that the CTG on whole board is the same baby. I think sometimes on labor board we forget that an in utero insult has already happened antenatally. So we cannot disregard that CTG that's happened on whole board because it's the
yes,
same baby. It's the same baby. So our management plan should not ignore the previous CTG.
no, we are not ignoring. I'm saying,
it's not ignoring it. Yeah.
no, I'm just,
Yeah.
we are not ignoring it. I'm answering the point. Is it valid to take her from HOPE with this abnormal CTG with 2 centimeters to theater? Yes. But also, this is not a blanket. In HOPE ward, she is 7, and you are taking her to theater. No, she is 7. She is para 2. She is involuntary pushing. Yes, labor ward. So it is, we are not here doing, again, I don't like the blankets. I don't like, if you do this, you find this. And if you see this, you do this. No, it is case by case. This baby is compromised from antenatal. You take her to observe. Okay, hat off to you, no problem. But you take her and the CTG is staying the same to the point that, let's say, Nagib is thinking, oh, this contraction and this CTG is suspicious or abnormal. Let me give terbutaline. Okay, fine. I'm giving terbutaline with abnormal CTG, with meconium at 2 centimeters. I'm also saying to myself one thing: give terbutaline and move to theater. Thank you very much. There is no other answer. Is not give terbutaline and wait. Similarly, a similar case, exactly carbon copy of this case, 5 days ago or whatever.
That one's for next week, Mr. Nagib. Don't ruin it.
Okay, fine. But again, 2 centimeters, and you are giving terbutaline and so on. You cannot say, oh, let's do it and leave alone.
But Mr. Nagib, will you make a different? Will you make a case for will you differentiate or segregate if it's a primary gravida from a para 2, considering the fact that in some situations, if it's a multiparous woman might progress with the next VE, but if it's a primiparous woman, she may, you know that she has a long way to go. Will you consider that?
Can I just say, Emmanuel, this goes out to everybody. If we have an abnormal antenatal CTG with multiple risk factors, we cannot just bank on the fact that she might progress quicker. And actually, I think if you did a statistical analysis on it, our para 1s tend to progress a lot quicker than our para 2s in a lot of situations as well. Not that that's relevant, but we can't just sit on an app. We're not classifying this as normal, suspicious, pathological. You can call it whatever you like. She's not in labor. She's 2 centimeters dilated. If we go by that, the generic rule of they'll progress a centimeter every hour, which is routine for a multip, she's still 2. We've still got, a minimum of 8 hours left. We're not going to put a baby that's already showing us signs of hypoxia through another 8 hours of hypoxia, specifically where we've given sibutylene, that hasn't fixed the situation for more than an hour. We can't just continue and continue and continue. If it's abnormal, something needs to be done about it. We can't always use a sit and wait approach just because we know that she might have a normal vaginal delivery in we don't know how long of a period of time.
So Dagmar has said, overall picture, para 2, query gestational age and placenta reserve, shallow decels, large baby, induction, tachysystole, shrom, MEC, terbutaline. She is giving a summary to Emmanuel. 340 and at call, for, I think C-section is the correct call. Contractions are either due to A, blood abruption, B, uterotonics, but propus out more than 30 minutes and had terbutaline, so not really anymore due to iatrogenic action. C, infection, inflammation. D, spontaneous, uncommonly associated with tachysystole. Here we have plenty of contraction again, so my thinking is infection. This is Dagmar's comments. Right,
Thank you,
let's
Mr.
proceed.
Najib. Thank you. Yeah.
Thank you. No, but the main thing here, Emmanuel, is as we always, we don't know which case, we don't know whose case, we don't know anything except one thing. We want to learn for tomorrow, and we want to learn for. And by the way, nobody has the absolute knowledge. Neither me nor you nor Kara, nobody has the absolute knowledge. We are all thinking prospectively, and we don't like to think retrospectively because so far we don't know the outcome of this. And we, even in the actual scenarios that either in this case or the next week's case that Kara is saying, when whoever commented on the case on the time did not know the outcome, but it is a prospective approach. So nobody knows, and we might be wrong. You can proceed, Kara, please. Yeah.
I'm going to go to the sort of end result now, guys, because I'm well aware of the fact it's now 8:10. This baby was born with APGARs of 8, 10, and 10. Unfortunately, this is the same cord gas. I would imagine we're more likely here to be venous as opposed to arterial, just based off of the fact that the gases often are. pH of 7.24, base excess of -1.7, and a lactate of 4.4, glucose 4.4 as well. This baby was on the 98th centile, weighing 4280 grams. So Dagmar, you're pretty much bang on when it came to your anticipation of the weight here. This baby had tachyapnea throughout the evening, was obviously on meconium observations. There was a little bit of a delay with escalation for a few of them because there was no subcostal recession or issues with the breathing, and saturations were normal. But this baby, unfortunately, required intubation at 27 hours of life, a persistent high oxygen requirement, and massively tachyapnic. And was actually transferred to a tertiary unit after 54 hours due to query meconium aspiration that we couldn't manage on our antenatal, on our neonatal unit. This baby is back with us now, is still on respiratory support, has been extubated, however, but this, yeah.
The baby was not cooled.
No.
Okay. Thank you so much, Kara. It is absolutely fantastic. And thank you, Emmanuel, for the discussion, and Dagmar for the comments, and everybody for the comments. It is very lively, and this is how we all will learn. Thank you very much.
Thank you, everybody.
Thank
It's
you.
a great.
Bye-bye.
Thank you. Thank you.